Which brings us to the management, what's often a panel then of diseases. Let's talk about the challenges that clinicians and managed care providers are encountering with this kind of challenge, Dr. Calabrese.
Sure. Well, obviously, the challenges are numerous. I think, when patients are presenting with comorbid, multiple comorbid conditions, the issues that you run into are, disjointed care. It's all of the things that healthcare reform today is setting out to try and address. There's fragmentation, there's lack of coordination, there's ineffective communication amongst, members of the healthcare team, which translates into adherence issues. It translates into polypharmacy issues with these patients, which, in turn can translate into adverse drug events, where, we know today we spend almost as much in this country today in managing drug misadventures as we do on the drugs themselves, which is a frightening thought.
That's terrifying,
because, and when you have these patients with multiple comorbid conditions being treated by multiple clinicians in many instances who don't necessarily talk to one another, it's a recipe for disaster. And the patient today is forced to try to maneuver this very complex system where there are competing demands and competing messages from one clinician to another. They don't understand where the priorities lie. And in many of these instances, these are silent diseases. They're non-symptomatic in many instances, so they don't recognize, they haven't been educated appropriately or actively engaged in a way that is going to help promote better care at the individual patient level.
It sounds to me terribly unfair.
Right.
It's a huge burden to place on a patient. And for physicians who've had all the education and know the implications of this, to say, well, look at these folks, they're eating too much, they're not doing this, they're not coming to me in time, that's not fair, is it?
Right, no.
Well, yes and no, because at the end of the day, as was said, the driver of this epidemic is the epidemic of obesity. Now, I am very proficient in all those medications, and I'm willing to teach my patients also about all of these medications. However, one thing is very clear: I would not be able to fight gluttony. I would not be able to fight inactivity. Now, I'm willing to. And I think that the mainstay of addressing all this issue has to start with lifestyle modification and education, which many times is beyond the doctor in the office.
Well, and I think that's that's a key piece of the issue, and I think Dr. Calabrese touched on that with the fragmentation. If you look at a typical primary care provider, he doesn't have the necessary resources available to him to manage diseases that take a team. Primary care, internal medicine docs, family practice docs in their practice, if they want to send a patient to get diabetic education, go see a dietitian, well, they have to send them somewhere. Those folks are not embedded in their clinics typically. The model of care that we have in the United States is a great model of care if you're acutely ill. It is a horrible model of care if your goal is to treat chronic conditions. And that's really one of the big challenges that clinicians have. The other is payment for care. And that's the other problem that clinicians have, is they may know all the things that they need to do, but when it comes to telling the patient, well, we're going to have you go see the diabetic educator. Okay, now, and I'm also going to go have you see the dietitian. Well, okay, your insurance doesn't cover the dietitian, so that's $35 out of your pocket. Well, it may be a copay to go see the diabetic educator. Those aren't always great examples because a lot of insurance mandates will cover diabetic-related services. But if I wanted to go get someone to learn about medical nutritional therapy for weight loss, many insurance companies do not cover that. The mandates are all over the board. Now again, this is something that the Affordable Care Act is intending to try to correct. Again, how well it will do that is still up in the air, and we'll see. But really, you've got patient engagement as a challenge for clinicians. You've got the ability to provide them the education that allows them to make better decisions, because a patient who knows what's going on, who knows what's at stake for them, will engage in their disease state. We all see it.
And it's data. I mean,
Yep.
it's not just the education of the provider, but it's taking these reams of data that organizations like ours have access to, filtering that data and translating that data into useful information that can be delivered in a timely fashion, in a near real-time fashion, back to the clinician who doesn't necessarily know whether that patient's been adherent to the 6 drugs that they've prescribed for them, doesn't know what the OTC meds this patient might be utilizing or not utilizing on a routine basis, doesn't know, that Dr. Jones down the road has diagnosed this patient with with another condition that the patient isn't on any treatment at all.
It's a challenge also, though, for even, this is the flip side of that. Even when that information is available, the system I work in, Intermountain Healthcare, is very good at taking all that information and pushing it out there. There's an issue with provider overload on trying to even manage the information. When they do have it, they not only have to manage the patient, they have to manage the data, and then at the same time they're trying to make a living. So that's a challenge that our current healthcare system as it's designed fails to address.
And we're going to get into that again as later in the broadcast. For now,